Hello and welcome to the video. Today I'm going to be talking about understanding liver function test derangements in terms of the pathophysiology and the clinical application. So without further ado, let's get right into it. The liver function tests, or LFTs, are a commonly ordered set of tests which assess for liver pathology. The term liver function test is somewhat of a misnomer, as most of the components of this test don't actually test for liver function. Rather, a more appropriate term might be liver damage tests, as most of the components of this test actually reflect liver damage. The LFT panel commonly consists of the top 6 components as listed here. ALT and AST are both liver enzymes, where ALT stands for alanine aminotransferase and AST stands for aspartate aminotransferase. These enzymes are both produced by the liver and participate in amino acid metabolism. Because they are both produced relatively abundantly within liver cells, also known as hepatocytes, as the hepatocytes get damaged, these enzymes will be released into the blood, and their blood levels will rise. Thus, elevations in ALT and AST effectively reflect hepatocellular damage. ALT production is thought to be more specific than AST for the liver, and hence ALT elevation is thought to be more representative of hepatocellular damage. There is still a role though for testing for AST, as it gives you more information than just the ALT alone, which I'll discuss a bit more later. The next components of the LFT are the ALP and the GGT, which stand for alkaline phosphatase and gamma-glutamyltransferase. ALP and GGT are found in cells of the biliary tract, and so biliary tract damage will lead to a rise in ALP and GGT in a similar fashion to how hepatocellular damage leads to a rise in ALT and AST. Furthermore, ALP and particularly GGT both undergo biliary excretion, and so in cases of biliary obstruction, the levels of GGT and ALP will rise. We'll talk more about this later. The next component of the LFT is bilirubin. Bilirubin is essentially a breakdown product of hemoglobin that is released from degraded red blood cells. As a waste product, it must be made water-soluble to be able to be excreted through the bile. This process occurs at the level of the hepatocyte, where bilirubin is conjugated, or more specifically glucuronidated, by an enzyme known as UDP glucuronyltransferase. The conjugated bilirubin then becomes water-soluble and is able to be excreted through the bile duct and through the gut. The conjugated bilirubin in the gut is then processed by the intestinal flora to become urobilinogen, which can be further converted into stacobilin, which is what makes stools brown, or the urobilinogen can be reabsorbed through the intrahepatic circulation back into the blood, where it's filtered by the kidneys to give urine its characteristic yellow color. Therefore, if there's an interruption to the excretion process for bilirubin, namely a biliary obstruction, then the lack of conjugated bilirubin forming stacobilin will lead to pale stools with an absence of the brown color, and the backing up of conjugated bilirubin back into the blood will lead to increased amounts of bilirubin in the urine, which will give the urine a characteristic dark brown color, known as bilirubinuria. Because bilirubin excretion relies on glucuronidation, which occurs in hepatocytes, bilirubin can be considered as a marker of liver function, as in liver failure with reduced number of functioning hepatocytes, there would be less bilirubin conjugation and therefore an elevation of serum bilirubin. Albumin is the next component that is part of the liver function test and is considered a marker of liver synthetic function, as albumin is produced by the liver. It is also a useful test to assess an acute phase response, where albumin will typically go down in an acute phase response. I talk more about the acute phase response in another video, which I'll put a link to here. Low levels of albumin can also be a marker of chronic and severe malnutrition. It would have to be chronic and severe, as the liver has relatively good reserve until end-stage liver disease, and albumin has a half-life of about 3 weeks, which means it would take a long time for the albumin level to drop. PT, or prothrombin time, is another marker of liver synthetic function. The liver produces a number of coagulation factors, namely factor 2, 7, 9, and 10. These factors are involved in the extrinsic pathway, otherwise known as the tissue factor pathway, which binds with factor 7 to start the pathway. Thus, in states of severe liver pathology, which is compromising liver synthetic function, the amount of coagulation factors, particularly factor 7, will drop, and therefore the prothrombin time will increase. And lastly, we have the platelet count, which is also a marker of liver synthetic function, because the liver produces thrombopoietin, which is an important growth factor for megakaryocytes, which ultimately form platelets. And so, with reduced liver synthetic function, there will be less thrombopoietin production, and therefore a lower platelet count, known as thrombocytopenia. This can often be one of the first signs of early cirrhosis, or chronic liver disease, where the thrombocytopenia may precede any significant LFT changes. And so, high-risk patients, particularly patients with significant alcohol intake who present like this, should be further investigated for evidence of chronic liver disease and alcoholic cirrhosis. So now that we understand the LFTs, which are the first 6 tests here, and the tests which assess true liver function, as shown by these bottom 4 tests here, we can move on to discuss the different patterns of LFT derangements. LFT derangement patterns can be broadly classified into either hepatocellular or cholestatic derangement. If the LFT derangement is predominantly in ALT and AST, this is considered a hepatocellular LFT derangement. If the derangement is predominantly in ALP and GGT, this is considered a cholestatic LFT derangement. And this is because the liver enzymes have different respective locations as previously discussed. To determine if the derangement is predominantly hepatocellular or cholestatic, you can formally do this using a formula known as the R ratio or R factor, which is the ALT divided by its upper limit of normal divided by the ALP divided by its upper limit of normal. However, practically, you can just look at how many times above the upper limit of normal the liver enzyme elevation is. And so, for example, if the AST and ALT elevation are about 6 times above the upper limit of normal, and the ALP and GGT elevations are only about 2 times above the upper limit of normal, we would say that this is a predominantly hepatocellular LFT derangement. And vice versa for a cholestatic derangement. If the degree of elevation is relatively similar between the hepatocellular and the cholestatic enzymes, then we would call this a mixed LFT derangement. This is important because identifying the specific LFT derangement pattern can help us narrow our differential diagnosis. The first pattern is the hepatocellular LFT derangement, where there is marked elevation in ALT plus minus AST. This indicates that there is damage to the liver, which therefore leads to the damaged hepatocytes releasing these enzymes into the blood, and hence there is an elevation of these liver enzymes. Basically, all liver diseases can cause an elevation in the ALT, and so the hepatocellular pattern arguably has the widest differential. Common things include alcoholic liver disease, whether it be acute alcoholic hepatitis or chronic alcoholic cirrhosis, viral infections, particularly hepatitis A if it's acute or hepatitis B and C if it's chronic, metabolic associated fatty liver disease, or what is colloquially referred to as fatty liver, genetic diseases such as hereditary hemochromatosis or the much rarer alpha-1 antitrypsin deficiency and the very rare Wilson's disease, autoimmune causes such as autoimmune hepatitis, and other infiltrative causes such as sarcoidosis or amyloidosis affecting the liver, or malignancy, whether it be a primary hepatocellular carcinoma or liver metastases, and even infections such as hepatic abscesses or parasitic infections like hydatid cysts. There are also medications that can induce hepatocellular toxicity, most famously probably paracetamol. and they're ischemic and congestive causes of liver disease, where either a reduction of blood supply or a compromise of the venous return, or even thrombosis of the hepatic veins known as biliary syndrome, which all ultimately compromise the blood supply to the liver, can hence all cause hepatocellular damage. And because essentially all of these etiologies result in the destruction of hepatocytes, they all result in an elevation of the ALT and AST. However, we can further narrow the differential diagnosis by looking at the relative elevations of AST compared to ALT, which is called the Ritis index or ratio, and is defined by the AST divided by the ALT as a ratio. And so if the AST to ALT ratio is more than 2, and particularly more than 3, this is suggestive of alcohol being an underlying etiology. But it can represent any other etiology that causes liver necrosis, particularly ischemic necrosis. This is because there's a differing distribution of AST and ALT in the hepatocytes, which is shown here in this stylized diagram, with the hexagonal-shaped hepatocytes as well as a central vein which ultimately forms into the inferior vena cava and drains blood back into the right side of the heart, and the small vessels bringing the blood supply from the portal vein and the hepatic artery respectively, as well as the bile canaliculi bringing bile away from the liver. In this hepatic acinar model, the hepatocyte is divided into 3 zones, with zone 3 being the furthest away from the blood supply. Zone 3 has a much higher concentration of AST compared to ALT, and so particularly in hypoxic circumstance, specifically ischemic or congestive hepatopathy, zone 3 is most likely going to be damaged, and therefore there's a marked elevation in the AST. This mechanism, along with the ALT reduction because of pyridoxine or B6 deficiency in chronic alcohol abuse, is the reason why AST is markedly greater than ALT, particularly in alcoholic liver disease. When the hepatocellular derangements are very severe, there are generally only 3 main etiologies that can cause this. One being drug-induced, which includes things like paracetamol, antibiotics, anti-epileptic drugs, herbal medicines, and even things like the death cap mushroom or amanita. The other major cause is viral hepatitis, particularly hepatitis A, which can cause intense liver inflammation and damage. And the third major cause is hypoxia or reduction in blood supply, which can arise from reduced venous return because of hepatic vein thrombosis in Budd-Chiari syndrome, or severe right heart failure, and theoretically through reduced blood supply through the hepatic artery or portal vein thrombosis, although this is much less likely because of the dual blood supply of the liver. So to summarize, hepatocellular LFT derangements reflect non-specific liver damage, where very severe derangements can be caused by drugs, viral infections, or issues with the blood supply. And an elevated AST to ALT ratio is suggestive of an underlying toxic or ischemic necrosis pathology. Another index you can use is to look at the LDH to ALT ratio, which is usually greater than 1 in ischemic etiology, because the necrosis and cell damage leads to more release of LDH, and so you can get very high LDH levels, higher in ischemic etiologies compared to things like viral etiologies, where there may still be a significant LDH rise, but ALT is usually higher than the LDH. The next major pattern is the cholestatic pattern, which is a predominant elevation in the ALP and GGT. This usually reflects either a cholestatic state, which can be induced by things like medications, commonly antibiotics, or even states like being pregnant, or can reflect damage to the biliary tract. In infective diseases such as cholecystitis or cholangitis, or autoimmune or pre-malignant diseases such as primary sclerosing cholangitis and primary biliary cholangitis, as well as biliary malignancies such as cholangiocarcinoma. A subtype of a cholestatic pattern is the obstructive pattern, where there is a derangement in the ALP and GGT, but importantly also an elevation in the bilirubin. specifically conjugated bilirubin, as we've previously discussed. This obstructive pattern indicates there is some sort of mechanical obstruction along the biliary tract, which can be anywhere from the sphincter of Oddi all the way through to the intrahepatic biliary duct. I'll talk about the biliary tract anatomy very soon, but just to go over the remaining patterns, there is isolated hyperbilirubinemia, where there's a high bilirubin, but usually no more than about 70 or 80 maximum, with everything else being normal, usually indicative of something called Gilbert's syndrome, where there is a promoter mutation in the UDP1 glucuronyltransferase gene, and hence a reduced ability to perform conjugation, and so under states of physiological stress, there tends to be a buildup of unconjugated bilirubin. It is, however, important to note that Gilbert's syndrome is a diagnosis of exclusion, and so you should rule out an early obstructive cause prior to making this diagnosis. There are also rare genetic diseases that can affect biliary excretion, such as Crigler-Najjar syndrome, where there's a severe deficiency of UDP glucuronyltransferase, and other diseases such as Rota syndrome and Dubin-Johnson syndrome, all of which present in the neonatal pediatric population. The other pattern is that of an isolated GGT elevation, which can be due to excess alcohol intake because alcohol leads to enzyme induction of GGT. And there is the pattern of an isolated ALP, which may suggest a high bone turnover state, such as in osteoporosis or diseases with bone metastases or lytic lesions such as myeloma. Now that we understand these patterns, we can go on to discuss causes of obstructive LFT derangement by looking at the anatomy of the biliary tract.